Our next session for today is to be chaired and moderated by our respected chairpersons and panelists. May I please request Dr. Monotosh Paja, Dr. Tapush Roy Chaudhary, Dr. Kunal Sarkar, Dr. Shushan Mukherjee, and Dr. Amarnath Ghosh to join the session as the esteemed chairpersons and panelists. And we have Dr. Ravi Kumar with us as the speaker. It's my privilege to introduce Dr. Ravi Kumar in front of you all. Dr. Ravi Kumar is the clinical lead and senior cardiologist in the heart transplant and MCS division of MGM Hospital, Chennai. He has 14 years of dedicated experience in heart transplants, ECMO, LVADs in Fortis Hospital, Chennai, Gleneagles Global Hospital, Chennai, and MGM Hospital, Chennai. He is also the founder member of the Indian Society for Heart and Lung Transplant, INSHLT. Dr. Ravi Kumar, it is time that we all hear you out. Thank you.
Good afternoon. Can you hear me? My voice, can you hear me?
Yes, you were audible, sir. You were audible.
You can help me to have the share screen, maybe you can see it.
Bottom of your Zoom window, you can see there is a share screen option enabled.
Yeah.
So you can go. Yeah, your slides are visible now. Thank you. If you can kindly make it full screen, that helps us best. Thank you.
Is it okay? Is it okay?
Yes. Yes, absolutely.
Yeah. So good afternoon. Thank you, Dr. Shuvro and Dr. Soumitra, my old friend. Also my seniors, Dr. Tapas and Kunal Sarkar. So, I know them personally, and many thanks for inviting me here for this session, prestigious session of the West Bengal CSI HF. So, can I start now, or should I wait for the chairperson?
Yeah, please start. Go ahead.
So, anyway, thank you, Dr. Shugro mentioned at Soumitra that just give a talk on how to set up a heart transplant program. So here we have been running this transplant unit under Dr. Balakrishnan for the last 10 years. So we just share our experience. I'll make it a bit brief and cut out all the technical or many parts of it, because it's a bit of a long thing, so I had to shorten the session. So as everyone would, all of you would agree, the outcomes in patient hospitalized is heart failure, especially the severe heart failure, the outcomes are dismal. And the 1-year mortality might even, by all international criteria, about 33% to 3 years might even exceed that. So generally these patients are not going to live for too long once the diagnosis is done and they have recurrent heart failure. So the goals of treatment, of course, are known. And then now coming down to the classification, there is one classification which is traditionally known to cardiologists, is the NYHA, which is 1, 2, 3, 4. And ACC-AHF has done another classification, ABCD. So D is the refractory heart failure requiring intervention. But we from the heart transplant and MCS side basically rely on this INTERMAX classification. So it's interagency mechanical assist registry. So here the start from 7. So the severe grades are 3, 2, and 1. So 1 is like cardiogenic shock, 2 is patients who are sliding on unstable on inotropes, and 3 are who require on and off inotropes. So now in our experience, for example, the last 89 cases, majority of cases are dilated cardiomyopathy. Of course, many are ischemic. Some of them are the other diagnoses, like restricted, non-compacted, left ventricle, children, etc. Just in the last few cases, just to give an idea, screenshot. So it's very important that in heart transplant, there are two aspects. So one is the surgical aspect. Surgical aspect is the anatomy part, where there's a transport of organ involved, safe transport, myocardial preservation, and then the actual surgery and the surgical bleeding control, etc. And then there is immunobiology part, because we have to, this is very important that the organ is basically unrelated organ. So it's very important that there is no hyperacute rejection, no acute rejection, and so that the immunology part also is very important, the matching, which I'll just briefly touch on beyond this. So is there an ideal recipient for heart transplant? In a country like India, especially, we face the challenge of very late referrals. And also there's a financial economic problems. So there are many patients who are on the gray zone because of various end organ problems. So the ideal case, which is perfectly right, would be very less. So what are the problems which affect patient selection? Basically, it is cardiorenal syndrome, liver congestion, altered liver function, pulmonary hypertension, nutritional issues, frailty, physical deconditioning. This is ISHLD, International Society outcome and survival graph. Basically, the US, basically, this is data which shows that the 1 year survival is around about 80-84%, and 2 years around 75%. So who needs a heart lung transplant? So heart transplant, basically people, classical cases are end-stage heart failure, could be any diagnosis, EF less than 25%, or it could be a severe RV dysfunction, not LV, it could be a severe RV dysfunction. Others are postpartum restrictive, congenital heart, post-surgical, etc. Ideal age is less than 60 for the recipient. So these are ISHLT criteria for listing criteria for heart transplant. You can refer it. It's 2016 by Dr. Mehra et al., which actually gives how to select a patient. So the broad clinical indications, recurrent heart failure, we also check something called VO2 max. So the VO2 max is less than 14. Those are the cases which need a transplant. There could be other diagnoses like recurrent arrhythmias with structural heart disease, a failed LV assist device, failed or RV dysfunction post LVAD, failed congenital heart surgery. There could also be failed other devices like failed CRTD with increasing RV LV failure with probably RBBB, failed mitral clip. We have seen 3 cases, failed LVADs, failed post CABG and post PTC LV dysfunction. So what are the contraindications for heart transplant alone? So this would be one important aspect is irreversible pulmonary hypertension. So this is, we actually check the cath after milrinone and IV's intrapulmonary sildenafil or nitric oxide, and still if the transpulmonary gradient is more than 16, PVR more than 5, then those are not the cases for heart transplant alone. So that means for a heart transplant, we need actually a TPG less than 16. High creatinine levels, which are the structural renal disease, again may need heart and kidney. Where advanced hepatic fibrosis, portal hypertension might need heart and liver. Actually, it is advanced stage 3-4 malignancies, age more than 75. We don't choose such cases. So the renal dysfunction, basically the eGFR should be less than 30, creatinine more than 2. We have to reassess again after decongestion inotropes. Grade 2 renal parenchymal disease is a relative contraindication. Hepatic dysfunction, the MELD score is what we take, or a portal wedge gradient. If the wedge gradient more than 10, then this is not the ideal case for heart transplant alone. Heart lung transplant, commonly we do for Eisenmenger, PPH is RV dysfunction, or congenital heart disease with failed surgery or severe pulmonary hypertension, pulmonary artery. Now, important thing in heart transplant is a matching. So this matching is basically based, one of the criteria is AB blood group, ABO, just like any blood transfusion. Rhesus groups are not important here. Body size, very important that the donor size is, we generally take 10% up or down. The antibody screen is done so that there's no anti-HLA antibodies of higher level. And the allocation, of course, depends on the organ transplant authority, which is either NATO or whichever state you are. And this is again important that this matching criteria also takes into account the predicted heart mass, body surface area, and for donor factors could be age, the donor myocardial heart function, recipient factors are multiple depending on urgency, whether it is on MCS, age, etc. So for example, a classical donor recipient, we would actually see all these like recipient age, recipient blood group, donor age, donor blood group, etc. So the modern techniques which we use for elevating the effect of high pre-op pulmonary hypertension in the recipient is we actually use many things, because in India, PAH is not that uncommon. We get many cases with PAH, but which are reversible with sildenafil or IV milrinone on the cath table. So we do oversizing of donor, we avoid undersizing, we use preoperative sildenafil, ambrisentan, nitric oxide on the table. Sometimes might need ECMO or CPB support. There could be need for elective RVAD, etc. So the evaluation, these are the basic tests, right and left heart cardiac pulmonary testing with VO2 max, other viral torch markers, panel reactive antibodies, and also for carotid and peripheral disease. So the pre-transplant, the main important hemodynamics, what we see in the heart is cardiac cath, oxygen consumption by VO2 apparatus. We check the PA mean minus wedge mean. That is one of the most important criteria. It's called transpulmonary gradient. So with this, we calculate the PVR. We also check the RV stroke and work index, especially if you're going for LVAD. And the PVR should be done after milrinone and nitric oxide. RV function is very important. PA elastance and other criteria we keep seeing nowadays. So these are the basic metrics: TPG, PVR, PAPI is very important for LVADs. And so TPG less than 16 is suitable for heart transplant. But on the other hand, for LVAD, we need a PAPI more than 1.8 or 2. It's basically a metric of the RV function. So vasodilator testing in heart transplant. This is very important because we keep emphasizing to cardiologists that as per the ISHLT listing criteria, 2016, the PA systolic found more than 50. in the CAT table, vasodilator testing, test reversibility is very important. This generally we do now with all cases with IV milrinone, intravenous or intrapulmonary sildenafil or nitric oxide. So we see whether the pulmonary pressure come down, the transpulmonary gradient when PVR falls. So very important for us because in the time of transplant, the recipient donor RB should not fail because of the high PVR. So these are some of the just classical cases like TPG 17, but after milrinone and sildenafil, they fell down to 7. So these are reversible cases. So this was the example. Patient A at 56 years, his PA pressures are high. The PA wedge is 26, TPG is 22, but it falls to 14. TPG falls to 14 in vasodilator drugs. But still, you would take more longer time in the ICU, and RV dysfunction could be a problem. On the other hand, a patient B is 43 years, his PA pressures are lower, TPG is only 8, and RA is 10. So these people generally get away very well post-transplant. So this is some of the things we published like PVR and elastance on the recovery parameters. This we probably published in ISHLT in San Diego 2016, 17, I think. So this is mainly one of the grid factors what we take to decide between the heart transplant versus heart lung. So if somebody's RV function is good and PVR is low, then the therapy is LVAD or heart transplant. If the RV function is poor and PVR is less than 4, is heart transplant. If the RV function is good but high PVR, then LVAD can be done. So LVAD is basically more it can tolerate higher PVR. Other than RV function is bad and PVR is also very high, then heart and lung combined. We also check biomarkers in the waiting period, as some other speakers had mentioned, NT-BNP to guide the therapy and prognosis, etc. So because the event rate, bad events become high if the NT-BNP is high. The advanced transplant assessment will also importantly include VO2 max. We use a cycle ergometer, PRA, panel reactive antibodies we do for every case, class 1, class 2. Highly sensitized patients, that's how we identify. We also do the donor lymphocyte cross match during the type of transplant. Viral markers are also important. So this is just a picture of the VO2 max apparatus, what we use a portable VO2 max cycle. So every case we do, whichever case comes for assessment, we do a VO2 max. Because if the VO2 max is less than the 14 range, then those are the cases which everyone agrees that should be considered for heart transplant. Important problems in waiting heart transplant patients are cardiorenal syndrome. So this is one of the important problems. So although it is not CKD, still it is a cardio increasing creatinine and urea, and this can improve with short-term inotropes or mechanical assist device like Pentrimac. Liver congestion especially is very important. So if you have viruses more than grade 1, or the wedge gradient is very high, like 5 to 8, then these people may not do well in the post-operative period. So it's again well proved by our data, also by international publications, that if you're high CVP pre-op, then these people don't do well. They have worsened renal function post-op period. And in our cases in Indian Heart Journal, which we have published, Balakrishnan et al., in the 257 cases, we also found that patients with high RA more than 15, their survival outcomes are less, not so favorable. So what are the drugs we use pre-op is IV milrinone. We use home milrinone, even admission, and beyond that also for 1 or 2 weeks to decongest the patient, improve renal function. This is the equipment which is available in the US, but here in India, we use one of the multi-rate infusers from Baxter. Because of cost is much cheaper, costs around 2,000 rupees. So this is the regulator of the drug. So again, many trials have shown that pre-op milrinone surely improves the prognosis in the waiting period. For advanced heart failure and cardiogenic shock, this is a very important problem because every patient is not going to be stable. Many are going to be in shock. So in such cases, we may need what is called mechanical circulatory support, or MCS. So what are the MCS? So this is again, both AHA, JCC has given this as 2A-B status, the MCS for selected patients in severe heart failure. So the poor prognostic factors, for example, cardiogenic shock is well known, oliguria, high lactate, JVP, etc. So in these cases, we have something called as bridging. So that means these cases we bridge from cardiogenic shock or heart failure into either transplant or LVAD. So we use most commonly the ECMO. So VA ECMO, suppose a patient has cardiac arrest or goes into severe acidosis, we do an ECMO. So very early ECMO, and we have saved many patients on this. So you can see the arterial cannula, venous cannula, and the distal for 6 or 7 catheter we use for limb salvage or improve the perfusion in the distal part of the limb. And this is another device called Centrimac, which we use very commonly. So somebody has a biventricular dysfunction, we can support both right and left through this external pump. And these patients can even wait for 2 months to get a heart. So this is how we have converted many patients from severe failure, century mag, and heart transplant. So this is a VAD pump, basically. This I already gone through. Now, basic immunosuppression is basically we use what is called induction therapy. This we use in almost every case where especially creatinine is high. So we use basiliximab or ATG. Common immunosuppression drugs are tacro and cyclosporin, mycophenolate, low dose steroid. Unlike the US, we use a much lower steroid dose in India, and we have very good success in our 450 cases out. And they are titrated as per the EM biopsy finding and the anti-HLA antibodies or self-reading. But number of patients have high preformed antibodies, the PRA is high. And in these cases, we do something called single bleed HLA to actually measure the antibodies. And if they're very high, then we use desensitizing drugs like rituximab pre-transplant. So these are the protocols, pre-transplant, IVIG, rituximab. These are basically methods to reduce the antibody burden. These are a publication from Indian Heart Journal 2020, I think. Medium 257 cases. We have done a 7-year follow-up. And the results I'll mention. So we have already 456 cases now. 118 are pediatric heart transplant. This is from Dr. Bala's unit. And 84% survival at 1 year. 71% has crossed 5 years. So we still have patients at 10 years and people who are going for golf and playing half marathon, going from half marathon, etc. So this, basically the quality of life for survivors are excellent. That's what we have found. This is from all India data. So conclusion is heart failure is slowly progressive and ultimately fatal disease. Heart transplant has been successful in the Indian setting now for the last 10 years, accepted as excellent viable treatment for advanced heart failure. The modern approach is to understand the risk factors and correct them using the available data. So I would stop here and any questions I would take for this.
Thank you, Ravi Kumar. I'm Dr. Panja from Calcutta. I want to first, how will allocate in the USA, the donor allocation system is there. How will allocate the patient for the transplant?
Yes, sir. So the Indian law is as per the Act of 2011, the Transplantation Act, UHA. So according to that, the state regulator, that means in Tamil Nadu, it is transplant, Karnataka is their own Jivat Sarthake, West Bengal could be. So they would be, we have to register all patients as first come, first served basis. So that means whoever comes here, so it's the Indian citizen, he can be registered, he'll get first priority. Foreign citizen gets the second priority. But as of now, there is no preference for any emergency cases. So it's a first come, first served. Whoever is first registered will get the first choice. So, but at the time of the donor, whichever alert we have, at that time, the state authority informs us, and we have to then decide. We can decide between 1 or 2 patients which are suitable according to the weight and blood group. Of course, that's what they only decide, but according to the weight and the clinical status at that time. So that's how the allocation goes. And once the final allocation is done by transplant, we actually carry out the transplant as per the protocol. If it is an international patient or interstate, we have to get the permission from NATO.
Thank you very much. Regarding the infection control or particular role of sirolimus, everolimus, as well as rapamycin, what is the role of the current status in India? Western countries are commonly used because anti-proliferative, anti-fibrotic.
So here, sir, we actually in our center we use it especially when the creatinine level is high, or if somebody has got a coronary allograft vasculopathy. So, for example, we are doing the angiogram every 1 year. That's our protocol. So, if somebody has a CAV proved by IVUS, also we try to do angiogram. Then those cases will get everolimus or sirolimus. Or if somebody has got a tacrolimus induced renal issue, so then there is no option at all. It's creatinine going up, we change to tacro and but as you say correctly, it is surely been proved for prevention of CAV and CMV level virus also less.
Dr. Ravi, young surgeon. Dr. Tapus, please.
Yeah, thank you very much, Dr. Ravi Kumar. You said most of the thing we need to know. But it's very specialist for cardiologists to exactly to deal with the peri-surgical part. I thought we shall be listening from you setting up a transplant center, because this is what is required. Now in, say for example, in Calcutta, we have got about 6-7 centers. We need many more. Basically, I think what we should like to know that a person or a team, if you want to start transplant program, they should make sure that there is a SOTO as well as NOTO present there, or they should talk to the NOTO to organize all these structures inside the city, and then send a team to place where doing regular transfer, like your hospital, or we send our team to Bala's. You remember that time Bala
Yeah,
helped us a lot, and then I think have a word with the cardiologist. I mean, our one of our problem is there is no designated. There are designated transplant surgeons, but there is no designated cardiologist amongst the cardiologists who would look after the post transplant, biopsies or checking up the liquid antibodies and regular follow-up to look for the regional abnormalities, the frequent follow-up. That is, I personally found that missing in most of the centers in Calcutta. At least one or two centers, I know they are doing it because I'm pushing them. But in my center itself, in Fortis, it's lacking. It's not because there's cardiologists are so busy with putting stenting and doing with ischemic heart disease. There is no, I mean, dedicated cardiologists for transplant. I personally think the cardiac transplant program should start from the cardiologist. One or two cardiologists must dedicate themselves. Then they should sort of encourage the surgeons to get trained, the team get trained, perfusionists, and as well as the structure. Say, for example, all the matching, the antibodies, HLA antibodies, they should, figure out which laboratory are going to do that for them. Either it's a hospital or some other hospital. We get it done from some other hospital. It becomes cheaper. So all these things, and as well as all the time keep the government, local government informed that what we are going to do. I think this is a very basic, but I think that is what I think wherever you should, when you give this talk of setting up transplant, this is you should emphasize because these have been you, me, everybody gone through this, these problems. And if there is a protocol, as a matter of fact, there should be a protocol from, say, for example, CSI West Bengal, that to set up a transplant program, this is what you should do 1, 2, 3, 4, and they can ask you, request you. There is no one better than you to just write down 1 to 20 steps how to set up a transplant program. And that's true for heart, lung, and most of the other transplant program. Thank you.
Yes, as you said, but we in Indian Society of Heart Transplant, we already prepared the documents and we have a ready-made ISCT, actually meant prepared by ISCTs. So we have a document as a pathway as well as a protocol. Now the problem is, as you say, heart failure centers. It depends on the heart failure center. So in your center, you remember you started in 2017, I think.
We have started, like I took over as a transplant program director from 2018 January. And then after 5-6 months and got in touch with Bala. You know that story. You know the story more than anybody. And then we did it in 21st May. About it got 5 months. But basically, I think this should be encouraged to the government hospitals. I encourage our government hospital like SSKM as well as Medical College, and they have done quite a few, about half a dozen transplants each, and most of them are doing well. Some of them have got long-term survival. So I think this is where actually common people, free of cost, will be benefited. I mean, that is what I think our transplant society should look after and propagate. How to set up and do more transplant. Basically, what I'm trying to say, Dr. Ravi Kumar, is that cardiologists must be dedicated themselves. That's the most important, to go from or divide their time between treating ischemic patient, putting stents, as well as leave some time for setting up a transplant. Unless it comes from cardiologists, it's very difficult to maintain it. Surgeons can do their just stitching, but this maintaining it is a very important for cardiologists to take interest.
But of late, so CSI, there are a lot of more interest in HF heart failure in the last 4 years.
It is.
It's a slow process.
And because your 1 year survival is 82% and 5 years survival is 72%. Is it correct?
Yes.
In your slides? Yes. What will be the cause of death? These patients survive up to 5 years.
Mainly, there would be many of them have died of some are rejection. About all that we have about 15% still rejection. So then some have infection, like some had CMV and some pneumonia, COVID, and then we have malignancy. So some of them develop non-Hodgkin's lymphoma, colon cancer. So these are some of the losses we have, but many of the losses are in the first 30 days. So the first 30 days, about 20% or 18% may not be, because all comers. So people who are sick.
Yeah, correct. Future that if the patient can long life, even 5 years, patient complain chest pain once again. Number one. Second, severe aortic stenosis also. That's because of how much scope of CVG. The SIFT trial only the provided, the survival will make long by the CVG. What your opinion? And TAVI also very important. After those are survive, if is needed, that is the TAVI in the case severe aortic stenosis, those survive. What your opinion in that regard?
So we do angio every year. So we have cases with coronary disease. So out of that, I remember our series about 6 or 7 needed a drug stent or drug balloon, and two needed a CABG. We have not come across aortic stenosis. TR is that. So out of native disease, it is mainly diffuse coronary disease or severe disease. Maybe it's donor or atherosclerotic. So these are one percentage surely is there. So but as you said, there is no chest pain in transplant cases. So that is another problem, because you will have silent kind of ischemia and silent.
In case of the failed syndrome, in cases of congenital heart disease, what is your experience?
For which
Failed syndrome surgery. In congenital heart disease, failing phantom.
Congenital heart disease?
Yeah.
So as we already analyzed at about 100 odd cases. So out of that congenital heart, we had many post-Fontan, post-Senning, many of them had combined heart and needed heart and lung also, some of them. But these cases mostly were post some surgery. So post-Fontan failure, post-pathology failure. So actually the children, I mean the results we had done over 100 odd cases. And the youngest one, of course, cardiomyopathy also. The youngest one was 18 months, just recently one failed. So the children, the results are fairly good, because renal issues are late in them. And if you get an organ in time, as in our program, somewhere we get, they generally do well.
In long-term follow-up, those the infection and reaction is there, but in spite of that, so many other complications, malignant process, new onset diabetes, hypertension, renal insufficiency, hyperlipidemia, and this graft vasculopathy and malignancy. What is your opinion in your long-term follow-up?
As you say, many somewhat developed higher creatinine levels and 1 or 2 CKD. So, but we put in right time, if you can spot them, we change over from stop tacro. So it's a tacro-induced creatinine. Then with everolimus, they generally do well. Some of the, of course, hypertension and diabetes now, many are new onset diabetes. It could be related to the steroid or the tacrolimus also. There have been reports that tacro-CNA can induce diabetes. But those are basically in follow-up manageable problems. But as we see it quite often.
I think, Dr. Ravi Kumar, if some of our recipients survive that long to develop hypertension and diabetes, I shall be pretty happy, because that means they are probably surviving 7 to 8 or 10 years. So, isn't it? I mean, nobody develops diabetes, hypertension so quickly. So, I think in West Bengal, I have just had a brief look at how the people in recipients eventually died. Actually, 80% died of infection because of very interesting, because there are so many renal transplant patients and liver transplant patients. They are taking also immunosuppressive drugs, but the cardiac transplant patients are more susceptible to infection. I don't know any particular reason for that, apart from CMV, even bacterial infection. The ones they get a pneumonia, very difficult to actually get them out of it.
I have a short question, Dr. Ravi Kumar, for after an excellent presentation. That in the present context of the paucity of donors, what will be going to be the role of this donor after the circulatory death, DCDs, because over DBD, which is now getting established in United States. So as you are leading one of the biggest centers in the country, are you making any effort with the government agencies to work out the strategies in near future? Because that is something which you are looking for, to get donors. That is the number one. And please, one more question is a very short one also, that with the advent of these new heart failure medications, ARNI, SGLT2 inhibitors, MRA beta blockers, and some more are in anvil, do you think that these are going to have a huge impact on the number of patients of heart failures, and that will finally lead to increase the burden of actual heart transplant recipient in the future? That is about
the first questions of our DCD. We had an internal discussion, especially Bala and we have actual problem is the government is yet to give any clear guideline or permission for donation with cardiac death. Because otherwise, some of the in-house donors what we had, we are actually prepared for a DCD retrieval. But the protocols, I mean, they are with the government. So problem is without government, we can't just do anything. So we have forwarded it to both NATO and now we'll have a discussion in our coming in INSHLT, Indian Society of Heart Transplant meeting. It's happening in Chennai next month. So we have called the NATO and SOTO people. So possibly, as you say, that could be one which can add. But my point is, there are many organs which are still going waste because of lack of logistics. Because see, our team, we are able to get organs from Chandigarh and Surat and Jaipur because we have a logistics team in place. So we are able to travel and get it. So what our statistics show is that many states are now donating, even PJ Chandigarh, but no takers. So if you are able to do a transplant, the logistics part is somehow is the most important thing. So
if I may add one point in this, what we have been suffering in West Bengal is that you see the donor actually they are in the standard ICCU and is a neurological ICCU or standard ICCU where brain death patients are there. So the problem here, this common RMOs in ICCU average, if you think of there are several 100 ICCUs in West Bengal, very few people can diagnose a potential donor. And even if they diagnose, because of the subsequent harassment, you can say expenditure, all these things, hospitals do not encourage that, put forward this patient as a donor. Because we have only 30,000 rupees or 40,000 rupees comes from ROTO. So, I mean, that is not enough. So hospital always they do not want to go through this. We just stay quiet about it. I mean, you never know what's going to happen. So this is where I have seen in South India, in your place, everybody is gearing up to, they're enthusiastic to find out a donor. Even there's a possibility they wait and see and do their best to make sure if this patient donor or not. They ask each RMO, they ask the same question. They're trained by that. But this is not the case, not even in West Bengal. Same thing in Assam, same thing in northern India. Why does northern India so much less transplant as compared to south? Because they are in so many ICCU in PG, Chandigarh area, in Delhi, in Haryana. But they are the ICCU RMOs, they are not trained to detect a potential donor. That was the main problem because there is no such a big center doing regular transplant. Although AIMS is there. So AIMS has got their in-house recipe, the donor. So that is I think this is a big problem.
One way it's overcome is Tamil Nadu is that one thing is the government has made brain death protocols and brain death declaration mandatory for under their jurisdiction, government hospitals. And that same, I think, in Karnataka also following now. So the Tamil Nadu, Karnataka, Maharashtra, Gujarat, these 4 states are now the performers there. Absolutely. But also they're taking NGO help. So like Mohan Foundation is helping many of to train the counselors, grief counselors. So that the doctors are not put, it should not be a burden on the doctors alone. Convince the relatives.
Not only that, awareness must be maintained. Awareness of the evaluation of the recipient, very also important. Patients should know the cardiogenic shock with the mechanical support, chronic progressive heart failure, the stage G heart failure, a refractory angina without any revascularization. So people should be aware that they will be interested for transplant. there is evaluation of the potential recipient also must be there. Otherwise, the awareness program is highly neglected in our country.
So today, Tamil Nadu government has made.
I just answer 1 minute. I just answer what Amunna's second question. That has happened to me many times. I think about 6 or 7 potential recipient who agreed for a transplant because of after taking ARNI and re-evaluation, majority of them are now unwilling to go for transplant because they're symptomatically much better. There's no doubt about that. Omar, I mean, ARNI has changed made a big change, particularly to the borderline failure. As a matter of fact, this transpulmonary gradient is in fact come down in some of the cases. So, I'm not very sure as a surgeon that we should really be careful which patient can continue with ARNI for as long as at least as long as he can arrange the fund for the transplant. One of the best bridging methods so far I have seen is ARNI. I mean, this is my personal opinion. People can differ. I'm a surgeon, but I'm still talking about ARNI because it is really excellent bridging medicine to quite
what Dr. Tapas actually is saying is that what exactly Tapas was trying to saying that this ARNI is going to make a change, is already making a change. Now, what is important that goalpost is changing or not? At what point we say that's a refractory medical treatment we choose for a heart transplant? That is something, a new thing is coming. That becomes a dilemma for the surgeons also, because as today's date, most of the person for transplant actually is routed through the surgeon in the city. We also face the same thing. So this is a small dilemma. Because of advent of these new drugs, we have started giving them. And at what point, as a cardiologist, as a structural heart cardiologist, you would suggest us that, yes, this is the cutoff point considered for transplant. This is not going to work in this case. This is another small thing which you can highlight.
As you mentioned, the 4 pillars, definitely we have found it postponing the type of many of the patients with moderate heart failure. But we also do the VO2 max. So, for example, we have many patients on ARNI. So, we do VO2 max every year. So, it's worsening, then we either do cath or MRI. Of course, there is a recurrent heart failure admission required. That it's postponed. So, that stage you can always
Even in spite of progressive heart failure and stage D, in spite of the CRT-D and ICD, patient going to die. So therefore, we have to pick up the patient from give up patient. Okay, thank you, Dr. Kumar. Excellent presentation and excellent discussion. Thank you very much. Thank you.
We will break for a short tea right now, and we will be back right on 5 o'clock. So till then, enjoy your tea, and we will be back right at 5 o'clock. Thank you.